introduce Kaitlin Martin.
Hello. All right, once I get set up, we'll be ready to rock and roll, which involves my stopwatch, so that I don't talk too long, because that's a thing. Okay. All right, just so I know which way this works. Nope. Oh, there we go. Okay. My clicker is very different. Okay, that I use in class. Okay. Hi, everybody. Okay, yeah. Okay, so hi. My name is Kaitlin Martin, and I've been an instructor at ECPI University in Raleigh, North Carolina for about a year now. I've lived in North Carolina for about 2 years, so I'm originally from Oklahoma, cardiac nurse by trade originally. Then I did some case management, and then I really fell in love with teaching my patients, and then they were crazy enough to hire me to teach students, so here we are. I like to fall down rabbit holes, not when I'm talking, I promise, but I like different topics, and so this is sort of how we wound up with this particular topic, where my master's thesis was on simulation, but it focused on talking about death and dying in healthcare, which is something I was really passionate about as a case manager, working with my patients, talking to them about what they really wanted after multiple hospital admissions. And then when we got to teaching with students and we were talking about therapeutic communication, I realized that I was giving them all of this information, and then there was no time to practice it because we had to get from this chapter to this chapter to this chapter. And so I was starting to, AI was kind of becoming a hot button topic. I know it still kind of is, but this was a year ago. And I was like, maybe this could help me, right? I want to play with this and sort of see, could this solve a problem I'm having, a problem my students are having. And so today, I want to walk you through how I've created this structured AI, what I'm going to call a simulation, since that's a little bit of my training, how it can support nursing students in developing some therapeutic communication practice in a safe, repeatable environment. I'm all about repetition. I want to identify some key prompting guardrails that can help keep them safe, but also can protect what I'm trying to do with my objectives when I'm working with them, and then how I'm applying this simple framework over and over again in different ways through the various classes that I teach, okay? But first, I'm going to tell you a story. So I was teaching one of my very first classes, and I was working with one of my students, and she's supposed to be inserting a Foley. So we're in lab, and she's supposed to be explaining to my mannequin the procedure before she begins. And she goes, with this big bright smile, "Don't worry, we do this all the time." And then she begins. And I was like, ooh, okay. And I was like, okay. So for those of you who are in education, or for my students in the room, right, that doesn't exactly follow your ANA, CUSIN, patient-centered principles, offering our false reassurance and all of those things. And so in my mind, I was like, okay, so note to self, when we're done with lab, we're going to review our therapeutic communication principles about how we educate our patients about our simulations and what we're doing with our procedures. But I didn't want to interrupt your flow, so we got through our skill check, and then we kind of came back around to that. But again, that kind of just reinforced, I wanted to give them a place. How do I give them time to practice? How do I give them a place when I don't have any more class time to give? And I've offered all the study sessions I can, but I still have to test you on this come Tuesday. How can I do this? And so I started playing around with AI and prompting and all of these things, and I realized over time, and a lot of failure, that I think AI has something to offer us as a really valuable tool. I'm not going to try to oversell it, I promise. But I think it has something to offer in this space where it can be a safe place to structure what's happening with my students. It can be, and I'm not flipping through my notes, so this is not helpful. It can be this safe, structured place, right? I can build what I want the AI to actually do. And because I use a large language model with my students, it actually can mimic a patient conversation, which means they can fail They can fail miserably, and I've seen it in class with them, but they learn something valuable along the way. And I can prompt the AI to do kind of what I want in that environment. I can make it short, I can make it long, I can have the AI give feedback based on the ANA and QSIN principles that I'm trying to teach them, right? Based on professional standards I want them to have, right? So this is what I'm talking about, where I think if you keep it simple, but you make it repeatable, it can be something that's really, really valuable. So first, what I do is I actually teach through my principles in class, right? And then I actually preview it. I demo it in class, what I want them to do with the AI. And then, so I simulate it, and then with all of my AI things that I've built with them, it actually is instructed to give them feedback, something they did well and something they can improve on. Because what I tell them over and over again in class is that nursing is a lifelong learning profession, which means that no matter how long you've done this, whether it's your first year or whether you've been doing this for 55 years, you have something to learn. Something to learn from your patients, something to learn from your colleagues, something to learn from something that was just published or a brand new medication. You can't know it all, so you might as well be humble, accept it, and realize that you can get better at whatever skill you're practicing every day. So they get feedback on that, and then I make them do a reflective exercise. They have questions they have to answer for me, such as, did I ask open-ended questions or did I give false reassurance? And they get to reflect on the feedback the AI gave. Is it accurate, for starters? AI can hallucinate. So was it accurate to what it was supposed to be? But also, what did they learn by doing this encounter? And then they can do it over, and now that we've done it together, they can do it as much as they want. Before clinical, after clinical, moving forward throughout the rest of their nursing program, for the rest of their lives, I don't care. They have the tools, go use it as you see fit. So, the prompting guardrails do matter, though. So this is something I want to definitely highlight here. And I'm going to, you know what? Skip. Okay. Sorry. So the prompting guardrails definitely matter, though. So for example, when I build my AI models with my students, there is absolutely no student information, so I'm not violating any federal laws. There's no FERPA problems for my educators in the room who know what that means. That's not an issue I have to face. My students are not required to input their information. There's also not a HIPAA violation because there's zero patient information that's going into this either. If any patient information is created, it's all made up within the AI system. It's not real, none of that is happening. Okay, so no student, no real patient identifiers. So in that sense, it's just like when we go into simulation and I have, for example, I did liver failure and we had Joseph Cuervo as our patient for the day, right? It's all invented. It's also about professional language, right? This is what I teach my students, which means it's what I expect from them, but it's also what I expect from my AI. Absolutely no profanity, bullying, or demeaning speech should be coming from my AI. The goal of this is for my students to feel safe practicing. Now, I will give a bit of a disclaimer. I'm working with my leadership because my bosses and my upper levels love the idea of being able to work on this for de-escalation tools and training some of our leadership students for more complex patient interactions. I haven't built it yet because I haven't thought of a way to make it safe. So we're not there yet. But for right now, no profanity, no bullying, no demeaning speech of any kind, and that's coming from the AI. It's also a time-boxed interaction. I keep it short because repetition is the key to learning, in my opinion, and that means I want my students to get as many reps out of this as possible. So 2 to 4 interactions, which means they can't say everything. So you have to maximize what you are saying, right? So even though my students are sometimes like, well, I wouldn't say that in my first interaction. And I'm like, that's fine. What did you say that mattered, though? If you only get 2 interactions with your patient, it needs to count. Also, there's a rephrase requirement. My students are expected to use professional speech, which means that if they're the ones using profanity or bullying the AI or using unprofessional speech, the AI will act uncomfortable or specifically ask them to rephrase or read or try again in the interaction. And again, balanced, moderate feedback. Like I mentioned, I want my students to realize that they did something well. So many of my students carry a lot of stress about talking to patients. I'm never gonna say anything right. Everything that I say is wrong. And I'm like, you know what? You said something right. What went well? Let's focus on that. So the AI is gonna tell them something they did right and something that they can improve on. It's also not gonna make anything up. I don't just do this for therapeutic communication for human connection. I'm gonna talk about how I also designed this to do medication education. And for that, I care about accuracy. So if the AI doesn't know something, we're not making it up. It's very important. And also, once my students input the prompt, the AI is not to reveal any of that prompt back again. The students have it so they can go back and review it, but that's not part of the process and that's not part of the sim. So we're not dredging up those instructions again once we're into the activity itself. So those are some of my guardrails. Now, I want to talk about different by design. I've already hinted at this a little bit. I think it's really important. I have a really kind of simple framework, but I do pivot based on the objectives. So I have one that I build for therapeutic communication, and it's geared toward human connection. My students are given 10 different prompts that they can choose from, and it's all about meeting patients or patient families in difficult situations. So for example, a patient who's just been given a terminal diagnosis, or a patient who is struggling with sexual identity, a patient, family member who's feeling guilt over choosing whether or not a patient should be taken off of life support, a patient who's getting a Foley catheter for the first time. These are all experiences as nurses that we will encounter, and more. But I have sort of a smattering of things that are difficult situations. This particular AI therapeutic simulation is built for human connection. Can you manage therapeutic communication in a difficult situation, right? With that, I want my students to actually be present and practice emotionally staying present while being professional in this situation, which means it has less structure to it, and I give the AI more variability in its responses to my students. I'm focusing on validation and presence, right? And so the feedback often emphasizes, were you empathetic? Did you connect? Were you person-centered? Now, on my medication teaching side, which are the two that I'm going to emphasize today because they are my two opposite ends of the spectrum, for medication teaching, it's very high structured. And we are often talking about something that's very high safety. Accuracy matters. Do my students understand about their medications? Are they giving accurate information to the AI patient? Are they emphasizing things to keep their patients, for example, alive when they're going home on a chemotherapy agent? Do they understand what's important if your patient's on a heparin drip? For those of you in the room, and again, cardiac nurse by trade. So we talk about those kinds of things. So it's very narrow on what happens there. And again, the emphasis is often on accuracy and safety in that situation. So the two different prompts I'm going to walk you through today, one's going to be from my therapeutic communication side and one's going to be from the medication teaching side. So for my therapeutic communication demo, again, the objective is human connection. So I want you to look for reflection, validation, open-ended questions. Are we avoiding that false reassurance, giving advice? We're going to try a first try, and then we're going to try a second try with our student demo here. And for full disclosure, I have shortened these just a bit to make them more readable on the slides, but also so that the AI can be a little verbose at times. So the AI says, I'm really nervous about this. They said I need a catheter, and I know it's probably not a big deal to everyone else, but it feels really embarrassing to me. I don't like the idea of being exposed, and I'm worried it's going to hurt. I have questions, but I feel a little ashamed even asking them. And the student responds, that's okay. We do this a lot, I promise. I'll take good care of you. And the patient shifts uncomfortably in the bed and gives a small, uncertain nod. And the AI says, okay, I mean, I'm glad you've done it a lot. It's really personal, you know? I've never had one before. Do people usually feel a lot of pain when it's put in? And will there be a lot of people in the room when you do it? And the student responds, sure, I get that it's personal. There shouldn't be anyone in the room except me and my instructor because as a student, I can't perform the skill without supervision. I'll close the door and provide privacy though, promise. You shouldn't feel pain, but let me know if you do so we can stop, okay? And that's it. That's the whole interaction. So, the feedback. My student is told one area to improve. The opening statement. I promise we do this all the time. While it's well-intentioned, this can sometimes minimize the patient's experience because what is routine for the staff is new and vulnerable for the patient. And what's interesting is that I can say this all the time when I'm standing in front of people in class, but they hear it from, like they read it on the AI screen or they hear it from their AI and suddenly it clicks. What was supportive? Acknowledging feelings. I get that you're nervous. This shows recognition of the patient's emotional state, which supports ANA Standard 1, which is assessment and CUSIN, patient-centered care by acknowledging the patient's perspective. My student realizes they did something right while they were going through this. The final feedback. Overall, your communication showed good patient-centered intent and safety awareness with a small opportunity to further strengthen emotional validation and open-ended exploration of concerns. So there we go. That's the whole thing. My student gets a chance to practice. We get a chance to talk about it in class. Usually I'm in a class of about 24 students, and they're all doing this on their computers at once, and so then I'm walking around and we're debriefing what went well, what didn't go well. If this sounds like a debrief for simulation, it should. That's how I've designed it, right? And again, the reason it works, my students are getting to practice this in real time. I'm not telling them what to say. They're shooting from the hip, right? It's their instincts, right? And what some of them have told me is that they didn't realize how it would sound trying to talk on their own without me standing at their elbow, guiding along what they should be saying, right? And so it's more valuable them getting to do that. And then I encourage them. You can practice the same scenario, or you can pick another. You have 10 to choose from. So the next thing I want to show you is my medication teaching scenario. As you can see, this one's far more in depth. And the AI has created a Robert Jenkins for us, but today we're going to be practicing working on heparin. And so I'm not going to read all of this to you, just know that it creates a whole patient profile for you. And then the patient says, I'm worried about the bleeding risk. What kinds of bleeding should I watch for while I'm taking heparin? And when should I tell the nurse? And when should I tell the nurse or doctor? The student responds, let's look at number 1 on this side first. We will monitor you for bleeding when we check on you. Let us know if you see any oozing of blood around the IV site. Thank you for explaining that. I understand you'll be watching the IV site, but I'm still a little unsure about what I should personally watch for. So in number 2, we see, that's a good point. Since the medication will slow down how quickly your blood clots, it's important you report any unusual or unexpected bleeding. So in your urine, stool, brushing your teeth, with bleeding gums, more frequent nosebleeds, etc. And also, you should avoid regular razors for shaving and switch to something less likely to cut you, like an electric razor. And the patient responds, that helps, thank you. I didn't realize even things like brushing my teeth or shaving could cause bleeding while I'm on this medication. And so that's it, right? They get 2 shots at it, and then the scenario ends. And so their feedback, what you did well. You explained the purpose of monitoring for bleeding and gave clear examples. Areas for improvement. Your first response focused mainly on what the staff is going to do, rather than what the patient should watch for and report. In medication teaching, patients prefer concrete examples, specific symptoms they can report. And actually it went on for a long time. Like I said, I trimmed it down. And then we get their final feedback, right? Overall, you demonstrated professional communication and appropriate patient teaching with a little more emphasis on patient-centered explanations and complete symptom lists. Your medication education will become even clearer. And again, it's reminding them, you have room to grow. This teaching session's complete, good work practicing. And then again, I have them do their checklist, their reflection. And then if we're doing this in class, which we normally do, when I teach pharmacology, then we have class time to discuss what went well, what didn't go well, how do we go forward from here. So, wins and losses, and what I want you to kind of take away from this. So, overall, I've had mostly positive feedback from my students. I had one student who realized that she was basically, during her education, realizing that she was blaming her patient for their medical condition. And so she was like, I need to change how I do that, which was a huge win, moving forward with her therapeutic communication skills, which is great. Overall, it's been really, really helpful for a lot of my students. Again, them practicing, not me telling them what to say. Some of the losses, though, has been frustration with new technologies. I think we can all appreciate that. And as an educator, it's another thing that I have to try to figure out how I'm going to fit into my class time when there are already so many competing demands for things that need to be done. But what I think is most important about what I've learned throughout this whole journey is doing this repeatable framework has helped me realize, by shifting it from objectives that I'm trying to focus on with my students, once I built one thing, it was easier to build it for the next thing. And it was easier to shift it to build it for the next thing, over and over and over again. And giving them the safe place to practice and build this kind of confidence is something that's really valuable to them, which is what I want and what you want and what their future patients want, right? I don't want them to be scared when they go to clinical to talk to their patients. And I also don't want to feel like a bully myself when I'm like, you have to go in there and talk to them, like that's your job, right? Because without talking to them, you can't assess them. And without assessing them, you can't do your documentation. And if you don't document it, it doesn't happen. So like we all have to figure out how to do this. But I think this giving them a safe space that's theirs. They can do in class with me, they can take on their own. I don't know. So again, I don't want to oversell what AI can and can't offer. But I think in this one space, it has something to offer all of us. And so take with that what you will. Thank you. Questions? Oh, yeah, sorry.
Yeah, I just want to say, I think your presentation was great, and what you've done is really, in this age of AI, is you have introduced to students a way for them to use AI, not only to gather information, but not to do the work for them, and not to use it as a search engine, but actually to use AI responsibly and to support their learning. So I think what you've done is a really good job.
Oh, thank you. Yes.
I don't want to get all geeky and techy because I won't understand it anyway, but in Claude, Copilot, Gemini, all of them, even ChatGPT, there's a margin of error.
Yeah.
How do you ensure they're right? If you don't know if they're right, do you cross-check somehow?
Yeah, so it's a great question. There is, so fun story, that you don't actually need to know a lot about AI to know this, but there's something called a temperature. And if you set it to 0.4, it reduces the, so everyone write this down. If you set the temperature on your AI to 0.4, it greatly reduces your chances for hallucinations. But also it helps that for therapeutic communication, we do have standards that we teach. So I don't have to reinvent that. My students, when they're doing their reflections and their self-checklist, they're comparing that to the standards that are coming out of their textbook from the ANA standards, CUSE and patient safety. I don't have to invent that. Those are professional standards that they're comparing their feedback to. So they have a checklist to compare that to that they have from class.
And who feeds this, your AI?
Oh, that would be me. It's in, so I didn't show you my prompt one because it's intellectual property, but two of my university, but two because it's a long one. But it's all in there. Everything that the AI needs, including its guardrails, it's in the prompt. And so when you put it in there, it tells the AI how to function.
Beautiful, that's great.
But it's about a solid, like an 8 by 11 page long.
And do they get to practice with human beings or with AI? Like practice responses and how to be with patients? I know a lot of people don't have time, but do you facilitate that?
So the AI is to help them. Usually I practice this, so I teach at a fundamentals level, usually before they're going to clinical. and most of my students are terrified that they're going to say the wrong thing when they meet their patients. So this is to kind of help give them some confidence before they encounter patients in real time. But then they're encouraged to come back and use it, keep using it in between those patient encounters. But then, yes, they do go to clinical and work face-to-face with patients. So they do have to talk to actual people. But when they practice when they're with their peers, peers tend to be too easy on each other. Oh, you did fine. And it's like, that was horrible. You gave advice and you did you did everything wrong. And so like when I'm walking around the classroom and I'm like, no, you really did. That was not a good try. Let's try again. So I find the AI holds them to a higher standard. I saw this one first, sorry, in the back.
Okay, if you can share this, what could training of the language model look like? Was it just all faculty? Did you utilize like actual patients? Like, I'm just very curious what
Oh,
training looked like.
so I use large language models that are already available. So I use ChatGPT. My university has one that they've built internally, but I haven't trained any of this, so I already use commercial models. So I haven't trained any of them myself.
First of all, I want to applaud you because this is phenomenal. This was really, really good, what you have done. And second, my question is that sometimes for intellectual property, when we are also working with our clients in LMS situation, what we do encourage them to use coding, because coding is one of the things which protects your intellectual property. Only a coder that you have hired would know unless you ask for specific codes. My question is, did you use coding in it, or did you just use the LMS? Man,
I just use the large
awesome.
language model.
Awesome, very good.
Yes.
I'm curious what feedback your students have given you as far as why they may prefer to get the feedback from the AI versus from you.
Yeah, so a lot of times, so part of the reason they can't all get feedback from me is that there's one of me and there's 24 of them, and so usually it has to do with time constraints. I don't have time to do one-on-one sessions with each of them to give them feedback on their therapeutic communication, even though I want to. I am a clinical instructor in addition to a didactic instructor, and so the groups that I have for clinical feedback, I am able to give them more feedback one-on-one, but if you're not in my clinical group, then they miss out on some of that feedback. A lot of them they spend a lot more time studying alone, and a lot more of my students, with the exception, I will say, with the exception of my older adult learners, a lot more of my students spend a lot more time alone, and a lot more of them are already using AI, but they actually don't know how to use it responsibly, and so I do feel some responsibility as their faculty to teach them how to use it in ways that are more responsible, that help them do this, and in a way that promotes their learning as opposed to taking shortcuts. And in that sense, I think they respond better that I'm coming alongside them and helping them use a tool that they're largely learning how to use in the dark, as opposed to using peers, and they're not really sure if, when they do peer-to-peer interactions, they're not sure if they're getting accurate feedback, and I can't be everywhere at once.
I think it is a lot more, it's like very blunt and to the point. So that's why I was
And some of that also has to do with how I've trained my particular model. I don't sugarcoat a lot of things in class, so I don't prefer that with my models as well. So, yes, sorry, in the back.
So I just echo everyone else's comments around the innovative nature of what you're doing. It's kind of courageous as well, I think. You're a bit of a trailblazer. So you said last year you were kind of just dabbling with this, and now a year, 12 months later, you're sort of presenting it. So, where do you see yourself in 12 or 24 months? Where do you see this going?
Yeah, so it's interesting that you asked that. My Dean of Nursing has actually asked me to make a presentation on what I've been doing in class to our clinical partners. And in doing so, that has opened the door for ideas that our clinical partners might have in directing how we use this more to fill gaps that they're seeing with our students in terms of communication, which means that I might have more, how shall I say this, requests on what I build, as opposed to it being what I see with my students. It might be more directed builds in the next 12 to 24 months to fill, especially communication gaps, since that's primarily what I work with. I know that I specifically have discussed with at least one clinical partner about de-escalation techniques, working with difficult family members and things like that. Again, safety is one of my primary issues. We're trying to do some of those builds, and so me and my assistant director of nursing and I are in sort of putting our heads together on how to build that safely and how to roll that out with the leadership group. No, absolutely.
It's really a silly one. I know that this is like more like on the didactic setting, but when it came first, like when your student just started, did any student of yours try to use it like a Siri? When Siri first came, everybody started asking them silly questions. Are you married? Did any one of your students did anything like that with your model?
Yes. So I actually, I had a student who actually reversed it the first time. Like, instead of them being the nurse and the AI being the patient, they tried to reverse it to where they got to be the patient and the AI was going to be the nurse. And then they tried to submit that to me. And I was like, and so at first when I was reading it, I was really confused because I was looking at it and I was like, huh? Because it was really good for starters. And I was like, this therapeutic communication, like, this is not what I'm used to seeing. And then I was like, wait a second. Luckily, the reason I caught on, though, is my student has really specific phrases that they say on a really regular basis, and that's what they started inputting as the patient. And I was like, you were the patient. Go back and do it again. Like, this is your assignment. Like, work with me here. So that was...
What'd they say?
Oh, I don't remember that part. I don't remember now, but I just remember, like, when I finally caught on, and I was like, well, now I feel stupid for not catching on sooner, but so I was like, the therapeutic communication is really good. And I was like, of course it is. The AI is literally just like copying and pasting out of the ANA handbook here. Like, of course they are. But, any other questions? Yeah.
I'm very amazed with your I use it and try to teach my students because as you said, they go to ChatGPT so it's better to direct them to the correct way they can use it. And especially regarding the references. I had a student, I gave her an assignment, she just put it there, and even her objective, everything come with citation. I said, what? So I decided that day to teach them how to use it. Because you can write your objective and come with citation. Because this is your objective, not someone else.
Right.
So, well done. I'm very amazed. Well done.
Thank you. All right. Thank you.